speaking again on treatment of osteoarthritis of the elbow. Again, disclosures. Looks like I'm going backwards here. Disclosures, royalty and consulting. As we discussed this evening, elbow arthroscopy is becoming a much more common procedure. And we're noticing continued advancement in the techniques, as we've heard tonight, with different diagnoses that can be treated arthroscopically. But again, just a reminder, as we've already discussed, is that with this new technique, is that there is a real potential for neurovascular injury. I've heard of every nerve, unfortunately, injured with elbow arthroscopy. I don't think we can make the risk of nerve injury zero. We can certainly try, but just as a warning, it's in the literature, but it's way underreported in the literature. And I just had a surgeon contact me just in the last month with a complete ulnar nerve injury. So we do need to be careful out there and to practice and come to the cadaver courses that are offered through the various organizations, ANA and the Academy and the Shoulder and Elbow Society and the Hand Society. I'll be talking about stiffness, but we've heard a lot of other indications for elbow arthroscopy tonight. Preoperative planning, x-rays, of course, are great, but often an x-ray looks just like this x-ray. You don't know where to start and where to finish, and so I now use a CT scan on most all patients. It gives me a roadmap. I can see the osteophytes. I can see the loose bodies. Posteriorly, I can see osteophytes coming off the medial side that need to be debrided, and it really gives me a roadmap. Sometimes I don't go in the back of the elbow if I don't see any work that I need to do there, and I'll concentrate on the front and stop if I achieve the motion that I need just in the front of the elbow. We can't forget that open debridement is still a good option. I still do a fair amount of open elbow debridement, so I think it's a fun operation. This is a view of the right elbow from the lateral side. You can do an approach that retracts the triceps and then split into the common extensor tendon, exposing the radial head. And by elevating ECRL off of the humerus, you can look all the way across to the medial side, looking down on the coronoid, and do an excellent release doing this. Here you can see a patient under tourniquet. Again, you want to preserve the lateral caudal ligament complex and not get into that, but you can work on the posterior and anterior aspects for good release. So I still do open in certain situations, mainly post-traumatic, and I think that's something we shouldn't forget, even though we tend to enjoy doing the arthroscopic treatment. I tend to prefer using the general anesthesia. I think you can use a block. I'm just concerned when the patients go home with a block. I'm really not sure if they have a nerve injury, and they'll be calling you to tell you they have a nerve injury rather than you diagnosing it. So I want to know when the patient goes home that everything's working neurologically, so I prefer general anesthesia. This is a setup that we use. I like to say the elbow is the highest thing in the room. If we have the I'll go back a little bit. If we have the elbow propped up on the arm holder, if we have the arm posed on the arm holder, that's good. I think the key is to get a low-profile arm holder. There are a few companies that make them, and the key is not to use what I would call a knee arthroscopic holder, but to use one that's a little low profile and holds the elbow up in the room. So here we can see the anterolateral pleural, which is a little circle, which is placed just above the rear capitellar joint. And I don't think it matters whether you start on the medial side or the lateral side, as long as you make safe portals. There's no one can tell you that starting laterally is better than starting medial or vice versa. Simply making a safe portal and knowing the relevant anatomy of the median nerve and the ulnar nerve if you start on the medial side, and of course the radial nerve if you start on the lateral side. And we can see here, starting just above the rear capitellar joint, can get you safely into the joint from a lateral approach. Once you're in the joint, you can establish a medial portal from inside out technique. And then you can do your bony work first, as you can see, working through your osteophytes on the coronoid, and then also off of the humeral side. And though the capsule doesn't really protect you from the nerves, at least gives you a clear definition of where you are. If you go after the capsule first, the muscle tends to float into the joint, makes it a little bit harder to see, and you're that much closer to the nerves in that area, so you want to be careful of that. You want to take out the loose bodies as you see them. Then after you finish your bony work, then you can strip the capsule, typically off the humerus, you can see here, and then do a resection of the capsule. Now you can see here I've left, we drew as if I'm leaving a capsule over the area of the radial nerve above the radial head. So I no longer remove the capsule above the radial head. I will detach it from the humerus and detach it from the radial neck and onto the coronoid. But to make it safe, I don't think it's a good idea to aim your shaver up essentially at the radial nerve. And you can see here in this anatomy, we can see how close the radial nerve is to the fat pad that's above the radial head. And here you can see at arthroscopy, we can see this is just above the radial head. You can see the radial head down at the bottom of the video. And literally that radial nerve, this is not part of the normal procedure for me, but you can see that radial nerve is right in that fat pad directly above the radial head. So if you inadvertently put your shaver up where I have the probe right there, you will indeed suck in the radial nerve. So I no longer think it's necessary to take that capsule off in that area. The median nerve is a little bit more protected, and posteriorly you can see here the ulnar nerve how it converges with the posterior capsule. It's literally on the opposite side of the wall, so to speak, from the posterior medial capsule. A loose body removal as a procedure, I think that's we initially did these, but loose bodies often a clue to osteophytes and tight capsule, and simply taking a loose body out may not be what many of these patients need. Studies, this from Adams et al. Showing you can achieve good range of motion here at 8 to 130 post-op in these patients by doing careful osteophyte removal and loose body removal. Posteriorly, in patients that do have ulnar neuropathy associated with their arthritis, you can do a resection of the posterior capsule. And I think the video here may run, but here you can see resecting the posterior medial capsule. You can see the ulnar nerve posteriorly. This is not a technique that I think should be done for someone that has only ulnar neuropathy. I think we have excellent small open procedures that can be done. But if I'm going to be in the elbow anyway, addressing osteoarthritis, taking out osteophytes, and they have some mild ulnar neuropathy, I will do an in situ release of the ulnar nerve. Again, Graham King showed also in his series excellent results using this technique for the osteoarthritic patient. Studies also from Europe and also from our own buddy Savoie showed successful results using arthroscopic technique for the osteoarthritic patient. If you actually look at the literature, there's actually not a lot that's actually written high-level prospective studies. So therefore, if you look at this paper from Dr. King's group, there's not actually a lot of great evidence confirming the results of arthroscopy for different situations. And in fact, for degenerative arthritis, the quality of the literature out there is poor quality. But importantly, we haven't shown that this is actually better than open procedures. And I think if you're comfortable doing an open procedure and you want to learn arthroscopic technique, I think that's fine. But I certainly not going to say that arthroscopy is better than open at this point, because we don't have true data to prove that it's better than an open procedure. I think my patients recover a bit quicker and get their motion back better, but again, we don't have great data to actually prove that down the line. And I think as you move along, and it's important to remember progressing with smaller cases before you tackle those significant osteoarthritic cases like that X-ray I showed initially. Well, thank you very much.